You're listening to In Good Health, the trusted news source for medicine, science, and technology. I'm Elizabeth Westfield.
I'm Mayan Vasta Betancourt.
And I'm Greg Johnson. This week, the age-related condition that many men ignore for years.
For a lot of patients that we see, they've probably had this diagnosis and these symptoms for well over a decade, but they didn't really think anything was wrong.
But first, should psychopathy assessments be used to influence the legal system?
People in the legal system think these scores are very predictive of risk, but in reality, we don't have evidence to suggest that that is actually the case.
All that and more this week on In Good Health. Across all mediums, books, television, podcasts, psychopaths continue to be a topic that captivates audiences. But Hollywood isn't the only institution interested in this community. Starting in the 1990s, America and Canada's judicial system heavily adopted the use of psychopathy assessments to identify psychopaths and inform legal decision-making.
The iteration of psychopathy assessments that we know today are these very structured interview protocols where you have a certain scoring mechanism where the clinician will sit down and eventually yield a score on the patient they're sitting with, and then that score will indicate whether they meet the clinical threshold of psychopathy.
That's Rasmus Larsen, a forensic epistemologist at the University of Toronto and author of Psychopathy Unmasked, The Rise and Fall of a Dangerous Diagnosis. He says there are a few main reasons why psychopathy assessments were implemented, one being that it's been thought this tool could predict which criminals would be high risk.
In other words, who are the individuals who will very likely recidivate if we give them parole, for example? Who are the individuals that we should put in high risk or maximum security institutions, and who can we give probation instead, for example? So there's been this need in the legal system to make those decisions always. And here comes along a tool that proclaims that it can help predicting who those individuals are.
Another reason why the system wants to identify psychopaths is because there's been a belief that these offenders can never be reformed.
They cannot be rehabilitated. They will never change. They will just stay dangerous and stay this extreme personality for the rest of their lives. And this information is important in a legal context in all sorts of ways. For example, if you have gone through a rehabilitation program, should we now believe that the person has changed and become better, so to speak? Are they now of lower risk than previously? Now, if a person has this label been assessed with psychopathy, the inference that the legal system will make is that they have probably not changed.
What this expectation led to was these inmates not being allowed into rehabilitation programs because not only was it thought that it wouldn't help, but it would make them worse. So while scoring high on a psychopathy assessment isn't a crime, Larsen says it can heavily influence a person's sentencing.
Sentencing is not just this straightforward catalog you look up, what did people do, and then it equals a certain sentence. No, there's all sorts of flexibility. It's often referred to as sentencing guidelines. So a judge has a lot of discretion. And a person who is considered very high risk, it might get a different sentence for the same crime as a person who's considered low risk. So the way psychopathy assessments enters the picture here is that it generates information to decision makers.
At face value, if psychopaths are a danger to society and unable to be rehabilitated, it makes sense that these assessments should hold more weight for how they're sentenced. However, Larsen argues that much of these beliefs are based off studies from the 80s and 90s that have been disproven by newer research. The early studies promoted 5 basic principles of psychopathy, which include that these individuals are high risk, untreatable, lack remorse and empathy, and have distinct brain differences. However, Larsen says these principles have been exaggerated.
In the 1990s and early 2000s, there was a lot of enthusiasm behind this research, and there was indeed also studies that seemed to suggest that all of these 5 claims have kind of been vindicated, if you will, empirically, right? What we have found out the last 10 to 15 years is very sobering. We have found out that that's not necessarily the case. It's not necessarily the case that we have really clear scientific evidence to support these 5 claims. So this is a development that has occurred in the research domain as these assessments were used in the legal system. So you could, if you want to be generous to the interpretation, you can say that in the 1990s and 2000s, it could, in some sense, be said that maybe there was some scientific evidence to suggest that it was a legitimate practice to use these psychopathy assessments. But when you stand from today's perspective in 2025, and also with the benefit of hindsight, we now know that the scientific evidence is just simply not there.
One example Larsen cites is the belief that people with psychopathy cannot be successfully treated. As we mentioned earlier, the fear was that any attempt to rehabilitate would actually make them worse.
Now, so the idea was that, or at least the myth, if you will, was that psychopaths are so cunning and so manipulative that if you enroll them in these rehabilitation programs, they somehow just like become better or more inclined to commit more crimes or something like that. I'm not saying it makes sense. This was just a myth that was out there.
Larsen says it stems from one study in 1992 that showed psychopathic individuals who received treatment also had higher rates of recidivism compared to those who didn't.
Today, we know that this study was not really a great study. It was based on some really problematic methods, including the type of treatment that was issued to these individuals, which actually a court in Canada ruled included torturing their patients. So they were kind of just, let's just say that maybe the reason why they were having higher recidivism rates were because they were being like maltreated in that program, right? So there's a long history behind that whole study and why we shouldn't believe it. And I don't think many people take it seriously today. That is virtually the only study we have that suggests something to that effect. But when you look at the research record in the past 20, 30 years, there's just overwhelming evidence that there's nothing unique about people with a high psychopathy score. They seem to react and respond to treatment efforts in exactly the same ways as your average high-risk individual would respond to it.
Despite these 5 foundational beliefs being largely debunked, the psychopathy assessments continue to hold a lot of weight in the legal system. There could be a successful argument for its influence if this method was proving to work at reducing crime. But Larsen says the results are hard to accurately measure.
If you really deem a person a high risk, like say an extraordinarily high risk individual, they will also be dealt with in a way that mimics that, meaning that you will often never really, like in a practical sense, figure out whether they truly were high risk because they will be in custody, right? So there's this self-fulfilling prophecy here. But the importance is that, to what we're talking about here, is that we can actually test it in different ways.
Psychologists have tested the actual risk profiles of people who have received high psychopathy scores and discovered that these individuals aren't as high risk as predicted.
We go into the judicial system and then we recruit a sample of, say, 500 people, and we issue a psychopathy assessment independently for our own research purposes to these 500 individuals. And then eventually, many of these individuals will be released from the correctional institution. And then we will track their future behavior, so to speak, if they end up back in the correctional facility, for example, what type of crime they ended up committing and so on. And what we find is that the correlation between a high psychopathy assessment score and future criminal behavior is not that strong.
In other words, being perceived as high risk based on this assessment doesn't line up with reality. The original criteria for this assessment to be used within the legal system was that it had to be evidence-based. But now that psychologists have proven the original evidence was faulty, why is it still such an influential tool?
So here you have the tension, right? People in the legal system think these scores are very predictive of risk, but in reality, we don't have evidence to suggest that that is actually the case, right? But the person is still being dealt with as if they are high risk, right? So this is the tension that we have. And this is the newfound evidence for the last 10, 15 years of research that we have found out as psychologists that, we might actually have generated an instrument that was initially thought to have these really profound capabilities of being able to predict something like high risk, where we're now finding out that that's not the case. So we psychologists are kind of screaming from the outside in to the legal system and say, hey, be careful with this instrument. But now it's kind of loose and it's hard to reel in, right? This is the problem we're finding ourselves in now.
The original criteria for this assessment to be used within the legal system was that it had to be evidence-based. But But now that psychologists have proven the original evidence was faulty, why is it still such an influential tool?
Really, at the end of the day, it comes down to our legal system being this very imperfect entity, right? We would like it to function smoothly, and we would like decisions to be based like profoundly on something like empirical evidence, scientific evidence, right? It's just simply not the case. It has certainly become much better the past 100 years, but it's still not perfect. So practices in the legal system does not change as quickly as the scientific developments.
In his book, Larsen provides evidence against the 5 core beliefs of psychopathy, but then takes it a step further. With research unable to support the foundational aspects of this disorder, he questions if it's possible psychologists have been wrong about the entire diagnosis. It's a controversial question, but one that Larsen believes is worth exploring.
When somebody has an idea, a conviction of how the world is, and the empirical evidence does not support that conviction, at some point you have to ask yourself, is this because the idea itself is completely wrong-headed, right?
Holding on to these beliefs, even when the evidence isn't lining up, is a concept referred to as a zombie idea.
The idea is dead, but it's still walking around in academic circles and in scientific communities as if it's like a real solid thing you should go and investigate, right? So I'm not saying that there are like all human beings are just fine and dandy and nobody are evil and bad individuals. Of course not what I'm saying. I'm saying that the specific claims that are made about psychopathy, such as that these individuals have no capacity for empathy, they have no emotions, they are extremely impulsive, all these like really key psychological claims, I'm starting to wondering whether we are just misunderstanding what is going on.
But as researchers work to tease apart fact from fiction, the psychopathy assessments continue to carry a lot of influence across the legal system, something Larsen views as a great injustice.
It really is a profound challenge that we're standing in front of. And it also tells you a little bit about how big, not just how big the problem is, but also the scale of the injustice when you start thinking it through, because we're talking about hundreds of thousands of individuals in the US legal system alone who are impacted by these assessments for no evidence-based reasons.
Larsen's book, Psychopathy Unmasked, is available now wherever books are sold. You can find more information about Rasmus Larsen and all of our guests on our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health Pod on Facebook, Instagram, and X. Our writer-producer is Kristen Farrah. Our executive producer is Amira Zavari. I'm Elizabeth Westfield.
Coming up, a deeper look at male menopause when In Good Health returns. Menopause is a well-known benchmark in a woman's life that signifies the end of her reproductive years. And though men don't necessarily have a similar point for their own fertility, they do experience an age-related process called andropause, sometimes referred to as male menopause. Lisa Fasone says that when men hit the age of 40, they start to experience a natural decline in testosterone.
The difference between male andropause and female menopause is women have a very abrupt decline in their estrogen levels with very abrupt onset of symptoms, versus men, because this decline is very gradual, it decreases by about 1% per year after the age of 40.
Fasone is a physician assistant with Northwestern Medicine who specializes in urology. On top of the natural decrease in testosterone, there are various lifestyle factors that can further impact hormone levels.
Men who have chronic diseases like kidney disease or diabetes, men who are overweight or physically inactive are at higher risk for having lower testosterone levels compared to their counterparts who don't have those diagnoses. So that also plays a role in how quickly the testosterone declines.
Having so many contributing factors means that it can be hard to diagnose a case of low testosterone. Fasone says most of the symptoms are vague, so some patients won't realize they're actually all connected.
Some symptoms of age-related low testosterone is fatigue, low libido or low sex drive, erectile dysfunction, mood disturbance, sleep disturbance, difficulty gaining muscle, difficulty losing fat. So those are pretty vague. There's a lot of explanations why an older man could have those symptoms. Some can be normal age related. Sometimes if a patient is obese and they have sleep apnea and they're a type 2 diabetic, those things could all cause all of those symptoms, right? So a lot of those symptoms are not specific to low testosterone. They can be multifactorial, meaning there could be a lot of different things at play causing those symptoms.
And since it's a slow process, many men don't notice anything's wrong until years down the line.
For a lot of patients that we see, they've probably had this diagnosis and these symptoms for well over a decade, but they just the change wasn't so abrupt that they didn't really think anything was wrong. Sometimes we'll ask patients, they'll say, I've had these symptoms for 10 years. And we'll say, okay, well, why'd you make your appointment today? What changed 2 weeks ago when you were scheduling this appointment compared to 5 years ago? And you'll have varying responses, but some patients will say, my wife got tired of me, complaining, and she finally made me schedule. Or, some patients will say, well, I had a medical problem and it really kind of made me look at my health in a different light, and I really want to take my health seriously. And so it's kind of moments like that in a patient's life where they finally realize that the things that they used to do or the things they want to do, they can no longer do. And then a lot of times that will prompt them to go see a healthcare provider.
Instead of dealing with vague symptoms for years, is it possible for men to be proactive about their hormone health? If the decline often begins at age 40, should that start routine screenings for testosterone levels? Unfortunately, Fasone says that wouldn't be effective because most men don't have any symptoms early on.
The technical diagnosis of hypogonadism or andropause is men have to kind of meet at least 2 criteria. They have to have low testosterone levels, meaning total and or free testosterone checked on at least 2 occasions, and have symptoms. So if a man does not have symptoms of low testosterone, the recommendation is not to test for low testosterone because they wouldn't qualify for that diagnosis regardless, right? If a man comes in, he's feeling great, he has no concerns, there's no reason to check for testosterone because he wouldn't probably benefit from having it replaced, even if it was low, because he's not symptomatic.
Testosterone replacement therapy is often the go-to treatment. And though emerging research is looking for more personalized and holistic methods, patients today typically receive TRT through one of several delivery options.
Main options are intramuscular injections, which is a solution that you inject into the muscle. Another option is oral medication. Generally, that's a medication a patient would take by mouth. It's a pill you take twice a day. There are topical applications, so topical patch, topical gel, or topical cream that you rub onto your skin daily. And there's also an option where a patient can come in, have a procedure done every few months where we insert pellets that are really slow acting. Those slowly release testosterone. The pellets get inserted into the glute muscle or the muscle in the butt cheek.
Fasone says choosing the route of administration is very dependent on the patient's experience with testosterone replacement and personal preference. Those who are scared of needles may choose to take daily pills, while patients who can be forgetful may not be the best candidate for oral medication.
Some patients, if they're around young children, I prefer they not use topical application because there's a risk of transferring that to a small child. If you don't wash your hands correctly or you don't put a shirt on right away, that medication can transfer to kids. And so you have to ask who's in the house with you, who has access to your medicine cabinet, stuff like that.
Research has shown that exposing kids to topical testosterone can cause premature puberty and enlarged genitalia. So having kids in the house can impact which delivery method a patient chooses. Fasone also notes that for first-time patients, she doesn't typically like to start with a pellet implant.
It's slow acting, but there's no way to take it out. And so if a patient didn't tolerate it well or didn't have good results from that, there's nothing we can do to reverse it. So I prefer to get a patient on some other type of replacement therapy first to make sure they tolerate it okay before we go to the implant.
The method of administration also plays a part in the side effects men can experience. TRT can affect various systems in the body, including acne, hair loss, and fluid retention.
Some of the main side effects and things we watch for is we watch for blood counts to make sure the hemoglobin levels don't get too high. That can increase a patient's risks for blood clots. There's also some studies to show that patients are at increased risk for heart attack and stroke with taking testosterone. There's been studies done that say that testosterone can increase your risk for prostate cancer. That's been somewhat debunked. There's kind of new studies that say not really, but what can happen is if a man were to get prostate cancer or be diagnosed with prostate cancer, the testosterone can make it kind of feeds the cancer and can make it more aggressive. And so that's something that we have to be mindful of.
Because of these side effects, some men aren't good candidates for testosterone replacement therapy. Fasone says physicians need to be cautious when prescribing TRT to patients who've had a recent heart attack, stroke, or have a history of breast cancer or prostate cancer.
Patients who have untreated sleep apnea should not take testosterone because they're increased risk for stroke. Patients who have uncontrolled heart failure as well, you have to be mindful of prescribing. But that sounds like a lot of kind of contraindications, but in the big scheme of things, that's very few. So most patients outside of that really would qualify and wouldn't have any contraindications to using it.
Which is great news because the benefits of this treatment can be life-changing. It can improve energy and mood, boost libido, and aid in maintaining bone density and muscle mass. Crucial components for healthy aging. You can find more information about Lisa Fasone and all of our guests on our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health Pod on Facebook, Instagram, and X. Our writer-producer is Kristen Farrah. Our production manager is Jason Dickey. I'm Greg Johnson.
In Good Health returns in just a moment.
Medical notes this week. Your next doctor's visit might come with a membership fee. A study published in Health Affairs reveals that concierge and direct primary care practices surged by over 83% in recent years as clinicians flee traditional settings to escape burnout and heavy administrative burdens. While these models offer patients more personalized attention and shorter wait times, this shift could worsen the national doctor shortage for the general public, leaving those who cannot afford the extra fees with fewer options for essential care. Your genes don't have the final say when it comes to your brain health. New research shows that controlling risk factors like high blood pressure can significantly lower dementia risk, even for those carrying the high-risk gene variant. Scientists found that genetic risk and vascular damage contribute to dementia independently, meaning that while you can't change your DNA, managing your blood pressure and cardiovascular health provides a powerful, modifiable way to avoid the worst outcomes. The research is published in Annals of Neurology. The hidden risk of suicide that has nothing to do with depression. A genetic study published in JAMA Network Open found that many individuals who die by suicide without a history of mental health struggles have fewer genetic markers for psychiatric conditions compared to those with documented warning signs. These findings suggest that conventional screening for mood disorders may miss a significant portion of at-risk individuals. And finally, when it comes to bone health, more is not always better for aging adults. Experts from Tufts University explain that while calcium and vitamin D are vital for preventing fractures after age 50, exceeding recommended doses can lead to kidney stones and even an increased risk of falls. Experts emphasize supplementing with the recommended amounts to maintain muscle strength and bone density without reaching the counterproductive levels seen in high-dosage clinical trials. And that's Medical Notes this week. I'm Mayan Vasta Betancourt.
Thank you for joining us this week and every week as we break down the science stories you need to know. You can find all of our past segments and guests on our website at ingoodhealthpodcast.org or wherever you listen to your podcasts. Follow us on Instagram, Facebook, and X for more behind-the-scenes content. Tune in next week for another edition of In Good Health.